So it's amazing it's gone that quickly. But before coming here, I worked running the office of the family physicians as a lobbyist and manager in the district, and then was a lobbyist for the American Academy of Pediatrics for 10 years, handling in both instances advocacy on payment, access, and different federal government programs and private payer stuff. So also was a lawyer in the United States Senate and for the Securities and Exchange Commission before that. So that was a lifetime ago, though. So I'm psyched working for y'all guys, for y'all.
Mike, you can come next.
Hi, everyone. Mike Horsfield. I'm currently president of APTA Private Practice, and my day job is the CEO of Rock Valley Physical Therapy, which is a physical therapist-owned practice in the Midwest. And as I look around on this call, there's so many more of you more qualified on payment than I am, so I'm getting a little nervous about this, but I'm looking forward to the conversation today.
Yeah, last year I think we had some billers on the call too. I'm curious to see if we have some repeat offenders. Kelly, go ahead.
Hi, my name is Kelly Sanders. I serve on the board of private practice. And also in private practice, I serve as the president of Movement for Life PT. We have four clinics in 4 states, primarily outpatient, primarily orthopedic, but we do a lot of care in rural areas. And I'm also the liaison to the Payment Policy Committee. So I get to work with a lot of smart payment people, probably smarter than me as well, as Mike mentioned.
Well, I appreciate all of you sharing all of the resources with us today, and I'm really excited to build on last year. I recognize a few people here, Martina, Nisha, Ashley, I think Diane. I think we got to meet at conference. Who was at last year's session specifically for payment? I think we did it in March last year. Anyone here for the second time? Nisha, Dave? Okay. Okay, great. I want to hear from all of you. So you can either do a quick introduction in the chat. So what's your role in private practice? Where are you located? And what are you looking to get out of today's session? And I might just I'm going to pick on Dave. You want to come off mute and introduce yourself? It's easy. I'm sorry.
Had to find my de-mute button. What am I answering?
What's your role? Where's your
Okay.
practice? And then what do you want to learn about payment today?
Yeah. So my role is short timer, president, CEO. My 40th anniversary with Kitsap PT will be Friday, August 14th, and that is the day I'm saying goodbye. So that's my short-term role, and just always wanting to gain insights. I know the folks with Bob and others working with Spark have provided a lot of great information, and always glean something from me. So appreciate the help.
Absolutely. So Renee, I see you're looking for strategies for negotiation. So Kelly is definitely going to help with that. And Amy, just here to learn, collaborate. Anyone else want to share something specific that you have in mind so that make sure we hit on it? Feel free to pop off mute. Anybody here for direct to employer? Okay, I'm going to throw a hard one out there. I want to know what to do about repricing. So I'm out of network, so we're dealing with a lot of the data eyesight. Anybody else? Nancy, yeah. Okay, so for everyone that came in, okay, I'm getting a couple thumbs up here. So for everyone that came in a little bit later, we want to make this more interactive. So the goal is cameras on, raise your hand or just come off mute. As long as that's not too chaotic, just jump off mute and ask your question. I don't want this to be passive, so this isn't meant to be a webinar. I'm going to be monitoring the chat throughout, and I'll make sure that everyone gets their questions answered as best as possible. At the end, there's going to be a survey that pops up. Please give your feedback there. Write as much as possible for us because we are actively planning how to make this session a permanent resource and planning out the calendar for next year's experts. So I'm going to start off with Mike. What is private practice doing to increase our payment? Let's get right into it.
Thanks, Stephanie. I think that, it's an interesting way to phrase the question. What is PPS doing and what can we not do? I think that's one of the things that we're really trying to clarify is what is the role of the association, particularly our section on payments. So what are we doing? I think, for a long time, we've been advocating at the federal level, along with APTA and other, aligned parties with advocacy as it relates to Medicare and the access issues and those things. So that is certainly something we've been doing for a long time. I think something that's newer that we're doing is we formed SPARC, which is State Payment Advocacy Resource Consortium. Bob's going to go into more detail on that. The origin of that was really trying to utilize our physical, the way our brains are wired as PTs, is we recognized that there were a lot of wins happening at the state level, but we weren't leveraging those wins into more wins. And so when we went and kind of got together with the ortho section and APTA on this, we asked the question, like, what are the factors, what are the conditions that is most likely to cause us to be successful in battling state payment advocacy? And it's when we've gone together, right? And it was direct access. The idea to get direct access in all 50 states was to deal with the compact. And so SPARC is an organization we formed, which is the whole idea of how do we learn faster, fail fast, fail forward, leverage these wins. And that's been exciting because you see a lot of the state wins have been multiplying and really gaining some momentum. And the last part that really, I believe, is where our lane in payment is for APTA private practice is to really help practice owners, one with business acumen. And a big part of business acumen is knowing your costs and being effective negotiators and getting payment contracts that can take care of both your coworkers and your patients, right? There's sometimes a balance of where you accept contracts that puts a lot of burden on your coworkers, whether that be admin burden or they got to see a lot of patients because the rates aren't good enough. But you want to take care of all your neighbors too, and that challenge. So again, through the negotiating series as well as just a lot of other resources, APTA private practices, volunteers and staff put out, I think is really help. Those are the three lanes that I see the private practice section helping with. And what we can't do, which I just have to end with, is we can't negotiate your contracts for you. Unfortunately, I wish we could go to every commercial payer and just negotiate better contracts. We can work on Medicare, and you guys know that's hard, but we can't. That's the part we can't do, and that sometimes is where maybe there's some unfair expectations or criticism that comes. But I know if you're on this call, you realize that. So,
Anton, I see you have your hand up. You can jump right in.
Stephanie, thank you. Mike, thank you for the great introduction. That was amazing. My name is Antoine Haiti from Brooklyn, New York, CEO of Optimum Health Physical Therapy, independent healthcare investigator, digging into the healthcare system that is so complex, so complicated, so abnormal for all of us who are clinicians and we don't have business background. However, in the past 5 years, I have learned a lot. I keep learning. It's endless of information out there. Now, to your point, Stephanie, you have brought up something that have been digging into data eyesight. Mike Bendermeer, Claritev, Multiplan, you name it. I have been investigating a lot into that area and pushing their buttons, including I got a letter from Claritev, which is Multiplan, silencing me from contacting the CEO, actually. However, I still have open channels with them. I'll be more than happy to give you some information, and whoever likes to join in a separate meeting, there's a lot of information out there on how to navigate those contracts and how to get out Multiplan, how to negotiate with data eyesight. By the way, Data Eyesight is owned by Multiplan. How to get insurance to stop sending claims to those TPA. There are ways where you can go to the insurance company and tell them the TPA that you guys are hiring or working with is doing unkosher business. They are not negotiating with me as a provider. I want to stop those claims from going to those TPAs. So I don't want to talk too much about it, but I'll be more than happy if you guys like to set up a meeting separately for anybody who is dealing with those passive aggressive approach and dirty work that's being done by those TPAs. I'll be more than happy to sit and talk about it for many hours. That's one. Number two, just one question. That's for Bob Hall. I've been following your YouTube videos, your Facebook videos. I'm getting a lot of great information from you. And I do agree 100% with you on getting out of those bad relationship with the insurance company, getting out of those bad contracts. Two questions, Bob, for you. The first question will be, to what extent do you feel like getting out of those bad contracts can lead to success and could put more pressure on insurance company to start negotiating higher contract and not really firing back on the small providers, given the fact that private equity and big corporations are invading the neighborhoods, and us leaving technically is not going to leave any vacuum for the members to seek physical therapy. They're going to have plenty of options out there. So it's being tough for us as a provider to say, okay, let's get out of a bad contract. How do you answer that? And question number two, to what extent do you believe legal path hiring attorneys to renegotiate our contracts can lead to success, given the fact that we don't have the ability to do so?
I'm happy to go, Stephanie, if you'd like me to.
Sure.
I want to make sure I'm following the format. Thanks so much for the questions, Antoine. And it's really good to be with you all today. I feel very lucky as usual. Two things that are on my list of things to do for this session are to talk about a couple resources that might be of value to you in that vein. First one is, I think we have a problem with PTs believing that they can do this. We have a problem with folks sort of assuming that they're never going to be able to succeed at this, so why try? And so one thing we put together is a listing of wins that we have been able to compile over the years and over time. And the goal of that really is to help persuade folks that they can engage in this, that even if they're a small practice. In fact, I think one of the most recent ones we got was from a response from a KPI survey, qualitative responses. This one PT told us, yeah, I had 6 contracts. I tried to renegotiate all 6 of them. One of them said no. 5 of them had increased payment rates. Right. So that is probably incredibly surprising to folks that can happen, but it does happen. And it's about finding the right person to negotiate with. It's about prepping before you go into there. And then it's also just, I think, fundamentally about believing that it's possible that can be done. So I'm just dropping in the wins document for you there into the chat. If you want to take a look at it, it's a Google Doc. We talk about what worked, and we're hopeful that's the bottom line, what worked for people, why was there a change, et cetera. And hopefully, just as Mike said, we can become a quicker learning organization where we're sort of teaching one another how to do this more effectively. Another thing, and I'll squeeze in a third, is that we are going to be having this session that's going to be a summit coming up in Portland, a little far away from New York, I know, but at the same time, it's going to be July 10th and 11th, so it's right around the corner. Hopefully, some of y'all will be attending that. It's going to be a very in-depth 2-day, 16 breakout session summit on how to do payment advocacy. And that is going to link a whole bunch of different things. Thank you very much for putting that in. And awesome, Antoine. I'm just totally psyched you're going to be there. There's going to be 4 different tracks. Some of it's going to be state legislative advocacy. That's not what we're focused on here. We're focused on private payer advocacy, to some extent, sometimes regulatory advocacy, because I think that's sort of an uncovered area, or an area that we could do a better job at covering. But this is going to be payer to practice level advocacy. It's a complicated mix, like you'd said, Antoine. There are ERISA plans out there that aren't going to be impacted by this. There's Medicare Advantage is a bigger entity now than traditional Medicare in terms of how many folks are actually enrolled. We're not talking about the VA. We're not talking about the Indian Health Service. We're talking really about the things that are regulated at the state level, which is becoming smaller and smaller in terms of how many covered lives are within those categories. But I still think, because this is probably the highest rate of payment, if not chunk of payment within the practice, it's really important to engage in this advocacy. A lot of folks sort of look at Medicare in the DC space as the sort of go-to that we should be focusing on. It's because it's easy. If you change one thing in Medicare Part B, stuff changes all throughout the system. Generally, not every payer follows everything that Medicare does, but it's a very effective strategy in the DC space to be focused on that. I'm a Medicaid guy, and I think it would be wonderful if Medicaid actually worked better for y'all to be able to actually afford to take those patients and then deal with the paperwork for those patients. Unfortunately, I think that that's going to be changing relatively quickly. It's going to get even harder, I think, to care for those folks as a result of some of the federal walk back from the Medicaid commitment. But really, the focus on Spark and on this, the stuff that I'll be focusing on, at least at the summit, is going to be on private payer advocacy. And that brings me to the third thing that I'm going to squeeze in here and hopefully not take too much time on. Mike was the lead thought leader on getting together a series of negotiation videos and how to contract more effectively. And really, I think some of the answers are going to be right in that, Antoine. I'm happy to put in that link for folks. I hope everyone is taking that, where our goal is to get 500 PTs through all 7 sessions of that. The first few are no cost to you. They just come with your membership. But as we get more in the weeds, it becomes a thing where you will have to add in some more resources, just like anything else that's on the Learning Center. So there are a lot of resources out there. I'm hopeful that we're able to also do casework. If there's something specific that you'd like me to dive in on, I'm happy to be responsive. That's why my email is up there and my cell phone number as well. So feel free to reach out in any way you'd like. I can take texts, I can take emails, I can happy to talk to you at the summit in person in Portland. So happy to answer any other questions, but hopefully those 3 resources: 1, the payment summit; 2, the WINS document to help persuade that folks can actually do this; and then 3, the negotiation series. We've seen a lot of results at the practice level from that negotiation series, and people diving in on that work. So hopefully that answers the questions.
If I could just add one more thing, Stephanie, unless you need to move on.
I was going to come to you next. Yes. So go ahead.
This would just be to add on. Mike had mentioned we do well when we work together. And one of the things that we can learn from some of our higher paying markets is sometimes it's through consolidation in these practices that are corporate, or where they come together under one umbrella or one type of network. But the other thing that I think you can do without being in those formats is work with your community of PTs. I'm not suggesting you collude, but you can educate each other on, what are my walkaway points, and what are the administrative burden things that we aren't going to accept in these bad contracts as a community caring for this area of the United States. What are we going to do in terms of being above our cost per visit? And, you don't want to get into the weeds of exact dollar amounts, but you can educate other practices and be collegial and do those things. And we have seen that work, and there are wins there. We stayed out of network on a capitated plan for over a decade, and they just came back to us 2 months ago in a fee-for-service model that's one of our highest payers in the region, because no one was going to contract with them, and they had network inadequacy issues. So that whole "we go farther together" concept, I think, is one we can apply a lot of different ways, and I think sometimes we overlook that.
Thank you, Kelly. And what I wanted to bring to you was that component of fear of, if I'm the only one who goes out of network. And, I'm also in Brooklyn, so I know how many physical therapists are around each corner. what else can we do at the individual level? So we are bombarding everyone with resources today. We sent out resources in the registration email. We've already put 5 resources in the chat. Where should we go first? So for the solo practitioners or people with a really small team, where do we start? And I'm going to bring that back to Kelly. Yeah.
Me. So you put the Spark website in the chat. So that's the first place you can go. And there's some, I don't at all want to say they're simple resources, but I do think they're easy things that you can use. Just appealing every denial you get is one thing you can do as a small practice, because the more you're going to appeal, that is a way to advocate for not only your practice, but everyone. But if they know you're going to fight every appeal, they're going to stop denying at some point. So there's some really, I don't want to say again, basic resources, but there's some things like that you can do as a solo provider. And to Bob's point, just ask to renegotiate your payment. You would be shocked how many people don't do that. I don't have the stats right here. I meant to pull them, but we did do a survey in our peer-to-peer groups, and then the KPI study to look at how many people had renegotiated a contract recently, and the numbers are pretty low. So if you don't ask, you're not going to get any change in your current situation. So I think that would be a first step. The other things are, make sure you know what your contract says and that you have a copy of your contract. A lot of practices we find don't even have a copy. And if you don't, that's okay. But call the payer and request it, read through it, and look at what those things are that you've agreed to, and make sure that you're actually being paid correctly given your contract, because we also see that sometimes that there are things that are being overlooked, or that you're not being paid even what you're contracted to be paid. So those are just a couple basic things, but there's a lot of resources on that site that we could probably spend hours going through. So please check out the Spark website. It's broken into multiple topics so that you can, I would recommend maybe tackling one every week or two and just trying to get through the resources there.
Perfect. Thank you. Mike, did you have something to add there before I come to Andrew? I see your hand.
No, as usual, Kelly covered everything much better than I did.
Okay, Andrew, go ahead.
I guess, Mike, has the PPS or the APTA given any thought at all into investing into accessing and processing the payer transparency files that legally they have to publish? I know they intentionally made them very difficult and massive, so like you and I just can't download them and look at them, right? Is there been any thought given to that? I think from a helping practices negotiate standpoint, that's one of the things we could do. So we could see regionally what people really are getting paid without really putting ourselves at risk of collusion or any of that kind of stuff.
Yeah, thanks, Andrew, for the question. It is something we looked at. There was 2 different vendors that were out there that were providing that data, and I met with both of them from the perspective of how could we get that data and then be able to get it to our members in a more cost-effective way than them going to these people who are doing that, right? They're going in and pulling that all and scrubbing it and getting it. We haven't yet. I'm cautiously optimistic, but we still haven't yet found a business model that aligns with their business model, right? Because if they sell that to one person who then distributes it to the universe, they've just lost their business model. And so we're trying to figure out, maybe it's a significant discount or whatever, but APTA itself has not looked into developing the technology or the software to be able to go in and do that ourselves. That would be a much bigger project, much more costly. So we're trying to partner with people who already do that and get it to everybody in a way that's reasonable for them to pay for.
Yeah, that was my thought, was that again, I don't know the cost to create the technology to process that, right? But I would think that if it's an extra membership fee on top of what we already pay, like that's certainly something that would be valuable and worth, versus me spending $15,000-$20,000. I spend $5,000 to get the information. It's totally worth it, right? And if 100 members do that and we get enough to build the technology, then maybe that's a strategy that had some
I appreciate the
opportunities.
encouragement, Andrew, that you feel that's valuable and worth us continuing to look into ways in which we can make sense out of that business model from both parties. So thank you.
Richard, what do you have?
So yeah, to that point, to Andrew and to Mike, to what we did in California is that we engaged one of those companies and came up with an agreement with them to access the data with the idea that we could run some specific comparative reports which could be shared with members without giving members access to the data. So as an example, we were able to take a geographic area like the San Francisco Bay Area and look at, you have to kind of do your research and get names of practices, but look at some typical PT practices in the market, look at hospital systems, and then look at physician practices, and then run a report by a specific payer, United Healthcare, Blue Cross, and look to see what the comparative rates were there, because that's kind of a high level look to see if there's a disparity between provider types, which in my mind gives you a good basis and a good argument from a contract renegotiation standpoint. And we did that, but the data was still so overwhelmingly complex that we weren't quite sure what we were seeing, because we weren't sure if the rates that were reported included a per diem or a day rate cap, or it folded into some sort of global pricing with a healthcare institution. So there are some nuances to that, but that was what we were allowed to do with that database. And I think it might be an approach that you may want to think about a PPS, that you're kind of taking kind of high level approaches on that, as opposed to showing everybody's rates for every PT practice in a geographic area. That's just kind of an overwhelming, and they're not going to allow you to share that.
Yeah, and
I think that was kind of what I was thinking of too. Like if you can show if we could have up for a geographic area, a median and a range, like that gives you something to work with where you can make some good decisions from a negotiating standpoint.
I think that's where we could probably get close enough. And Rick, that's the same thing we ran into, is it gets complexity by geography, and we're going to talk about why do different geographies get paid different amounts, right? Like that's one of our topics to talk about. That's complex, and we even ran it through just Rock Valley. We're in four states, so we have different markets, and we wanted to first test it and go, do they have our rates right? Like that's the only way we could validate. And it came back where it's like, that's not even exactly right with what we get paid in that area. So that idea of disseminating imperfect information, but to your point, Andrew, maybe it's good enough if we just get ballparks to everybody, right? So it's got to be actionable data, it's got to be good data, and that's we're still working through that. But I do think this is, again, we talk about leverage too. Payers have access to all of our data, but we can't get access to them. That's not right. Right? Like that's what the Transparency Act was supposed to do. And now they're muddying it up and making it difficult to find and creating it, costing us $20,000 to get it by practice. And they know we can't afford that. So I think working towards that and finding a solution to where we can level the negotiating playing field. We have our largest payer coming to us and they say, hey, we pay you more than what you take from United. Like, why shouldn't we pay the low rates? They know what we're taking, right? And this goes, I'm sorry, I'm on my soapbox, but Andrew, I'm going to kind of tie together what you and Kelly talked about is, a payer told me once, and I think it's the most helpful piece of information I've ever gotten. They said, we pay you what we do because we can. And we're not going to pay you any different until we can't. Right? And so that's network adequacy. That's honesty. It's brutal honesty. It doesn't feel good to hear that. But until Brooklyn people stop taking bad contracts, if I'm a payer in Brooklyn, I keep taking whatever, I'll keep paying you whatever you'll take. Like that is the hard reality. And it comes back to what Kelly said. But if people in Brooklyn can gather in a coffee shop and say, hey, let's be a little smarter about this without sharing price, without collusion, without that, maybe everyone wins in that situation. So I think that's where we have to get to.
Yep.
Kelly, I'm going to come back to you to follow up there. When it comes to negotiating, there's also the component of how we're demonstrating our value to payers. So do you want to talk a little bit about that? And potentially one of the areas that I was thinking about is the popularity of more objective tools to provide, like the Vault system or Kinetech, right? All of this technology is being introduced to us and marketed in a way where if we have this objective data, we might be able to prove our value. What do you feel about that?
Sure. So, absolutely. I think both patient satisfaction and our outcomes are important things to include in any renegotiation. So whatever those things are, collecting them. I've been surprised that patient satisfaction came up even over outcomes in one of our most recent calls. So collecting an NPS score, something that you can determine across your practice and by clinic, was really important. In this particular contract, they wanted it per clinic in geographic regions that they were looking for providers in. They had some adequacy issues. So I think that's important data. I think it's also important to look at your utilization. Is your utilization more or less than other people? And you may or may not be able to get that. Some payers will share that with you, some won't. But are you seeing the average rotator cuff repair for 40 visits, or are you getting good outcomes and high patient satisfaction in 20? So I would also look at those types of things as well. I don't know if they care, but we still also share our, what our cost per visit is. We try to be very transparent in what they're paying us and try to bring that into the discussion. And then the other thing that is that we've started to bring is any employer that's significant or physician that's significant. We've even brought in letters from them to put with contract renegotiation for why we're important to their outcomes or why we're important to the programs they're running or their contract. That's been helpful too. Employers seemingly more than physicians. But that's another thing that sometimes it's not data per se, but it is another thing that sometimes we will bring into the conversation in a renegotiation. The other data point is just what the wait lists are around your community. We actually secret shop or get the information from our patients too, especially in areas where access is a big issue. And we do try to list how many providers they have in an area, especially if they're getting close to a network adequacy issue, and then how long it takes for that patient to get in on average for a PT evaluation. And then we keep track of that in our clinic, and we let them know what our average wait time has been as well. So there's a lot of things you should track and understand about your contract metric, your contracts and your practice before you go into a negotiation. But in terms of what I share or what we have shared in the negotiation discussion, those are the high level things. The last point, again, also not a metric, but just any specialty services that you do. It was also brought up, suggestions if a payer isn't accepting your contract, and Bob touched on this in the chat, but whether or not you're in network or waiting to get in or not, if you do specialty care, especially if it's not readily available in your area, specifically pediatrics, vestibular care, we've seen some interest around certified hand therapy. Those things are also helpful too. We always include that in a letter of renegotiation as well, what services we're offering that may be at a premium or hard to come by in that region.
Any
Stephanie,
questions on this topic?
If I could run a thread through what Kelly said, which I think is very, very thorough. I think what payers care about is selling insurance and making money and having predictable costs. Right. And so anything that so the network adequacy issue is I can't sell my insurance if I don't have enough providers. So if they don't have enough providers, whether that's niche or overall, that's to your advantage to prove that. Right. I don't believe they want the cost to go down, but I think that they do want it to be predictable because they are using actuarial science to predict the healthcare costs for next year. And if it goes out of whack, they're not going to make their 15% of what that is. They can only make 15% according to so they got to hit that number. So that's where you're not having variation in your care or very predictable, lengths of stay. Like those things I think resonate to them. I think being the best PT in your area and having all these certifications and stuff doesn't matter to them. quite as much. That's why I always push down on the value or the quality. Does it really matter? Well, it does if it helps them sell insurance, make money, and have predictable cost. It probably does. If it doesn't lead to one of those things, I would like to be educated, or I'd like to, the optimist or the person who really is the ultrist, I guess is the better word, wants to believe they believe in quality care, but I haven't seen any incentive that's aligned with that yet.
But Mike, still a tool that can be used, valid tool out of all the tools that Kelly has listed. It's one of the valid tools that we do have to shove it in their face to tell them how good we are, even though it might not make a difference. Not.
I mean, I guess that the question is what is your desired outcome?
Yeah, it's by the end of the day, it's one of the tools. I mean, we're trying, because it's not all of the above that Kelly listed, they are going to work. Yes, we like the outcome. And if one door closes, we're going to try another door. If the one door closes, we're going to try another door. And we're going to keep on persisting and keep on trying all venues. I'm just talking from Brooklyn aspect, because they are like rough to deal with. And we have tried all what Kelly said.
Yeah.
Every 2-3 months, I knock on their door. I have emails of every single CEO of every company that you can imagine. I'll go to the executive. I have the executive email, CEOs. We keep on knocking on their door, and we try to find different ways. Whatever Kelly stated, we have tried every single approach. Some of them work, some of them doesn't work. But I don't think there will be harm to show them that we are good as well and what we're doing, and sell our services as a good practitioner, as an additional value out there. I think that's a great idea.
Yeah, that's fair. I'm not going to argue with that, and I think we should have that data anyway, right? So we should be doing that internally to ensure we're providing good care. And if we have it and we want to share it, it should be no extra cost. I feel it is a cost of doing good care, is to be measuring outcomes in some way. So it doesn't hurt to share that if you have it.
And I think what I heard in the way that Kelly presented the list of things that we can use versus the way that Mike presented it is messaging, marketing. Marketing is my thing. And basically, we need to frame what we have as our list of positive outcomes in a way that the insurance company cares about versus in a way that a physical therapist cares about.
And remember, some of these things may not be for the insurance company to hear. Some of them are for employers to hear. Like, I'm getting ready to go talk to our local university because we have some issues with the payer, and it's all of their employees have this payer, and the university has told us they want their employees to come to us. But my message to them is, we're considering going out of network. Here's why: because the university is getting a lot of feedback from their employees about the quality of care. So sometimes different people care about different things. And so you might want to also explore those areas if you have a significant employer that, you know, is utilizing one of those payers you need to negotiate with. We've seen, I have actually seen a school district on our behalf get all prior auth removed from our contract because she was a patient, and then she saw some of her employees having issues with prior auth, and she wanted people to be able to get back to work, but they were waiting 2 weeks to get authorization to come start therapy. So because we had the opportunity to talk to her in our clinic when she was actually a patient, she said, well, if that's the issue, I'll go fix that. So just always be aware of who's in your clinic and what their day jobs are, but then always think about, is there an employer I can share this information with, or arm my patient with this information to go back to their employer and have that conversation. It may not help as frequently, but we definitely see it help pretty significantly on some regional contracts.
Kelly, and I just want to expand on that's, I like that so much. And I think what I heard there is that you are not the customer of the insurance company. So they don't value what you think as much, but their customer is that school district who's writing them a big check for insurance. And if their customer tells them they want something changed in their plan benefit, they will do it, but they're not going to do it for you. And I think that is the key for us to keep connecting where the incentives are aligned. And I think the people where all of our incentives are aligned as PTs and what we talk about with value and decreasing the total cost of care and saving future benefit dollars, that's aligned with anyone. That's aligned with self-insured employers, and our patients, right? But it's not always aligned with the insurance companies because people turn over plans many years. So a lot of the, like Blue Cross's savings from PT keeping people healthy, those people might be on United Healthcare 3 years later, and now it's their problem, or they transition to Medicare and it's their problem, right? So this downstream savings cost isn't always realized by the insurance company, but those self-insured employer groups that are paying the first 100,000, 250,000 of claims, every dollar saved is a dollar earned for them. And they are telling the insurance company what they want this insurance to look like. And we're finding that same success of getting rid of copays, making it free, making PT first free, starting to get benefit design changed, but it's coming from the employer, not by us convincing insurance companies that we're saving them money. Because if you lower the cost of healthcare and premiums go down, insurance companies lose money, or they make less money next year, right? So I think we have to be honest with ourselves. We're on this call because we don't want the cost of healthcare to go down next year. We want to get paid a little more. And so do the insurance companies. And the only way both of that happens is the cost of healthcare goes up. But who's the person paying that? It's the employers. And it's us as consumers that now have higher deductibles and higher copays and things. So those are the people that are aligned with us.
And taxpayers.
And taxpayers, right? And so that I think just appreciating what message resonates with which audience is really important for us to consider as we're out kind of selling ourselves.
Super helpful reframe. Before we move on, any questions here? Because I want to transition into direct to employer. Anyone? I'm going to ask Nancy. Are you good? Okay. Kelly, do you want to talk about direct to employer a little bit? And I'll put the resource in the chat.
Sure. So a shameless plug, private practice section does have a direct to employer asynchronous course on the website that you can go through. And the really cool thing about that is if you complete the series, you do get listed on a database where we've actually had brokers ask us for that database to refer employers that are looking for consultants in MSK care. So do you want me to just go over what D2E is, Stephanie? Or talk a little bit about where it's used?
Are there any specific questions on it? Is anyone actively researching direct to employer right now?
I've been trying, and like we've been recently contracted with Hinge Health. It's with, I think they are a third-party company for finding physical therapists around. So I think is it similar to
it? So what Hinge is doing, as I understand it, is they are offering closed network contracts. So they're having one provider per geographic area, and they are having near site or clinics provide care to employers directly. So Hinge has a hybrid type model where they will send, they'll do digital care with employees. And then when they fall out of that digital care plan that they offer, they are looking for in-person clinics for people to go to. So that is one of the things Hinge is offering. So I guess it could be construed as direct to employer, but Hinge is actually the middleman coordinating that network. So what we're trying to teach people to do in private practice is go directly to the employer. So as an example, we had a contract with a General Mills cereal plant, and our clinic was nearby. So their employees that were injured were screened by a provider we had on site in the factory. And then they'd come over to the clinic for any specific care needs they had. But we would also manage a lot of things in the employer environment. So we had wellness programs. This particular population was a very aging workforce. So their average age was about 52, if I recall correctly. So employees had been in these roles a long time, had some more chronic MSK issues, but then also had a lot of general health issues. So the biggest thing we started was a smoking cessation program and a walking program. And then also had an athletic trainer on site to do a bunch of fitness programming. So my sense of direct to employer is if you've seen one contract, you've seen one contract. But being physical therapists, I think we're uniquely qualified to provide for the musculoskeletal needs of an employer directly. We found that you can be paid better than the typical commercial contract, but you're also right there at the beginning. So you're preventing a lot of injury. You're saving them long-term dollars by intervening immediately with their MSK and some of their general health issues on site or near site. There's lots of different ways you can do that. But you're getting paid directly from the employer. It doesn't go through the insurance. Your contract and your agreement is directly with them to help them figure out their MSK issues and general wellness issues. And then the other thing to think about is what we're trying to do in direct to employers. It's not the traditional, we just handle work-based injuries or workers' comp. We're managing total worker health there. So any health issues they have, most of these employers are self-insured on the commercial side, but many times on the work comp side too. So you are taking care of their employees, and then you're also taking care of their families in many cases, or their dependents that would be on their plan. Again, in a direct relationship. And we've seen, we're by no means experts in this, but we've had some significant contracts, and not one of them looked the same, because what Josh has really tried to teach in the course is that you need to go in and put on your problem solving hat as a PT and identify what their issues are, what their risks are, and how physical therapists can help with those issues. I think the one thing Josh says a lot is we're not going in to provide traditional physical therapy. We're going in with our physical therapist brain to try to help them solve problems with their employees. So I'd highly encourage you, if you haven't, we have a Q&A coming up. I'm going to have to look it up, but I'll put it in the chat. I believe it's July 25th that we'll go over some of those things if anyone's interested in learning a little bit more about direct to employer.
I just wanted to do a quick correction. It is July 15th at 1 p.m. Eastern. I have the link is in the chat.
Oh, Sarah is on it. Thank you.
You are awesome. Thank you so much.
No problem.
So does anyone have any specifics? Has anyone gone through the direct to employer series already and have some follow-up questions? Okay. If not, what questions are still on your mind that we didn't cover? Because I have a full list and I could keep going, but I want to know, Diane, what would help you the most? What do you want to use our last few minutes for?
Well, I actually think you've covered most of my questions early on about best practices in the billing area. I haven't done direct to employer, so I'm interested in it, but I feel like I'm a total newbie, and I'm gathering the resources. We'll plan to do the course through the private practice section. I think is super helpful. So all my bases are covered at this point with my knowledge level.
Great. Good to hear. Justin, do you have anything?
Hey guys, good afternoon. This has been very informative and beneficial. Correct me if I'm wrong, it seems like there is not one simple way to best negotiate reimbursement contracts with these payers for private practice. I'm in San Antonio, Texas. We basically see Medicare, Blue Cross, Aetna, and United, and that's pretty much it. Those are really by far, I bet you they control 90-95% of the market. And we've tried pretty much every year, and they literally tell me, Justin, we don't care. We have 10 providers within a 5-mile radius of you. So take our rates, don't take them, be in network, be out. We don't care. And so I feel ill-equipped to have a strong rebuttal that is effective in getting a pay increase. So no best practice, so to speak. I've heard a lot of ideas, but no best practice on renegotiating.
Bob, I feel like you have thoughts on this.
Yeah, I mean, so you can't collude, right? But everybody is in the same boat with you. It sounds like they're just walking away or willing to walk away. The payers, excuse me, not the practices. But you guys might want to have a cup of coffee together, and because the reality is that the payer has to have network adequacy, right? That is something that's critical for them to be listed as an insurance company by the Texas government. I used to work for Texas Department of Insurance for a minute back when I was in law school, but it is something that they pay attention to that. That the other thing is, if there are patients who complain to the state insurance commissioner, at least in Texas, I know there's a patient advocate who has to sit on this commission for the state. If that individual gets multiple, letters or communications from patients because they can't get in the door, or because they can't get to see the PT that they want to, or because the PT has fired that payer, that's another strategy you can follow. The other one is to, sort of a little different, but related to the direct to employer, is those patients can then go to their HR departments, right, and say, well, I have United Healthcare, but I can't get in the door anywhere. Or I can't get into the door in the place that I want to. This insurance is not covering what I want it to. So little creative solutions like that can sometimes have an impact. But it is absolutely hard work, right? I appreciate the work that you've done already. That's rough. Certainly doesn't. Hopefully, it's not a waste of time. I don't think it is if you invest in, interacting with the right people and wearing them down is what I think you have to do. You have to do your exercises in order to try to get them to be a little bit more open-ended, or at least willing to discuss it. But I'm happy to brainstorm with you at any time, Justin. And we have a number of letters that you can use. The other thing is the value of physical therapy report. I think, and sorry to go down a tangent here, but physical therapy is such a tiny spend for most of these payers, right? And really for employers as well. But it's such a good return on investment. So if you can stop some back surgeries from happening, if you can stop some total knees, if you can stop hip replacement, that kind of stuff ought to make sense to an employer. And then as a result, as was mentioned earlier, having the employers then say, why are we buying this insurance from this insurance company if our employees aren't able to come to work because they're always injured, right? Or if there are just different ways to sort of think about who's within the health system and how they're interacting. So anyway, hopefully that's helpful. But yeah, I'm happy to speak with you or ghostwrite something for you or whatever, that we can hopefully get to the right people within these payers. And then, yeah, if some folks have just decided that if they don't get any attention from the payers, they just get bigger. And I don't want that to be the answer, for everyone to get into these big practices. But, there are some things that they care about the network adequacy because the state does.
Okay. One last question. I've got hundreds. I don't want to monopolize this, but any ideas to how hospitals are so effective on negotiating their rates? So the hospitals in my area, they get paid literally 3 to 5 times what I get paid for the exact same treatment. I've seen EOBs where a patient was charged and paid $15 for 2 Tylenol, not Tylenol 3, not Tylenol with codeine. I mean, just regular Tylenol, 2 pills. The hospital got paid $15. That's just insanity to me. And I'm just want a 3% increase or, a 10%, and they're paying $15 for 2 Tylenol. How could they possibly be that effective? I mean, they're obviously enormously powerful, much bigger than I am as far as a corporate entity, but.
So Mike, do you want to take this one?
Yeah.
My list of just appreciating, depending on whether we're talking commercial or Medicare.
Commercial.
So with commercial, it's pretty much the main issue is leverage.
Okay.
Right. I mean, it is simply that in like Bob said, it's network adequacy in that market. You see what's happening with hospital consolidation.
Mm-hmm.
There's usually it used to be 5 hospitals. Now there's 1 or 2 maybe in each, depending on antitrust and whether the one could buy the other. That's what I've seen in our markets.
Okay.
And so for that insurance company, they need a hospital in order to sell insurance, and they have all the leverage. And so there's where the $15 Tylenol comes from. That's where the higher PT visits come. You'll hear something called so the other thing I want to just, because I get this question a lot, is this oh, I'm going to lose the parity in payment. Site neutral is the word you'll hear. Site neutral payment, right? You hear that buzzword going around. I want to kind of clarify that has to do more with kind of Medicare, how they pay us on the Medicare fee schedule, them on hospital payments. So there's different payments. It makes sense why it's different, right? They got to be open 24 hours a day. They got to have the emergency room. They got to take every payer, things we don't have to do. So they get paid different. What happened was now they started up in outpatient clinics that are right across the street from ours that are nowhere close to the hospital, and they're getting paid the same rates. Those got grandfathered in, some got grandfathered in, some still get paid under the old system with a little bit of an increase in cost. We think privacy bills about getting site neutral payment. They think we're going to get the hospital's payment. That is not going to happen. At least it has not happened when it's happened with surgical centers and other things. What's happened is their clinics will come down to our clinic rates and they'll go under the Medicare fee schedule, most likely. The opportunity will be, though, for private practice. The CEO of the hospital, when I was talking to him, we were talking about something else. He goes, hey, yeah, there's really no reason for us to collaborate now. But he goes, when he goes, if that site neutral payment ever comes, we might be back in touch. And I go, why? And he goes, because you guys know how to run a practice efficiently and we don't. And when we don't get paid as much, we're going to have to be better at running our business. And so we might need to work with you. So keep an eye on it. There might be an opportunity if that happens, but I don't think it'll be where we're going to get paid a whole lot more. I think it might be that they won't have an uneven playing field now to pay their therapists more. So recruitment might get easier because our payments will be parity. We might have opportunities to run their businesses for them. But that's just, I wanted to kind of, did I answer your original question? Okay, Justin, it's simply leverage. They need
yeah, I appreciate that. So I know we're not supposed to collude, but here's the crazy thought. If we unionize like state by state, would that increase leverage to a significant level?
Unionization is not leverage. Like it just unionization. I mean, if there's union, I will say that maybe I'm going to use a word, but if you look at an IPA, an individual practice, if you guys aggregate private practice under a single tax ID, we have one of those in our state Midwest Therapy Network where we contract and credential together. Now it gives you the idea of being bigger than you are, and it gives you a statement. I think there's a question, I'll try to wrap up. I know we're getting close, but collusion's come up several times, and I saw it in the chat of what is collusion and what isn't. Bob, I'll let you correct me on this, but we did meet with an antitrust attorney out of DC with APTA to kind of really say what can we say and not say and do and not do. It's pretty much you can get together and talk about things. What you can't say is this is what I get paid and we should all not take anything less than this rate. As long as you stay out of the of sharing your rates and sharing what you will and won't take, you're going to be okay. I mean, there's a group in Pennsylvania did this. They paused, and Highmark did a thing. They paused. It's going to be at the payment forum. Kenny Erb will be sharing this. But they paused as private practice and just said, no, we're not going to do that. Let us think about it. They got a letter saying you're colluding. Their attorney sent back, said, no, we're not. We're just pausing and talking about this. That's different. And so, again, this is where, again, more encouragement of get together with your competitors across the street. You know, I like the term coopetition. Like there's areas we can cooperate as private practice, and there's areas we can compete at the same time. Like it's okay to do both of those things. And I think that will help us all.
Thank you.
All right, down to the minute. I'm going to allow the last question. And if, we lose a couple people right at 2 o'clock, I just want to say thank you for spending this hour with us and remind everyone we meet every fourth Thursday at 1 o'clock Eastern, and we follow the In Focus calendar. So there'll be a topic and a guest expert according to that calendar. And I'll put the registration for July and August in the chat. Aaron, you want to close us out with the last question?
Oh, is that myself, Aaron?
Yes.
Sorry, Aaron Heyer. I am the president of New York's Private Practice Network, IPA. I do want to, this is a lot of great information. I think it's fantastic that there's being more conversations across the country, such as this meeting together. I do want to challenge Bob and a few others on collusion. I'm not an attorney. I don't play one on TV, but I don't like to hear the fact that you can't collude as a absolute. And I don't like to hear that the APTA can't negotiate as an absolute. I think colluding by getting together and advocating for each other's is certainly something that can be done. Mike had it right in terms of being able to specifically say, I want this rate, here's my rates. But we can certainly get together and we can certainly collude in saying we are advocating for fair and reasonable rates. And we need more respect in the profession and being able to negotiate simply by saying there should be more respect given to these private practices. I don't think that's illegal in any way, shape, or form.
I 100% agree. Sorry, I have to add something on that. 100% agree. There are certain limits that we can stop. We don't have to dig into the numbers, into the contract, but we can say no if we hear people getting paid 50, 60. We can go ahead and reach out and tell them, no, that's not acceptable. We're advocating for abnormal payment that should and must be talked about, is not renegotiating contract, but stopping severely underpaid contract. That's very harmful for the profession. They are out there and it's destroying the reputation of the profession. We have to do something for it. But yes, we should be able to do something. Thank you.
Yeah, Aaron, and I think that's well said. And I think that's where we're saying it. Like it's us just talking about collusion and the legal definition we can't do, but we can do a lot more together that doesn't cross the legal definition of collusion. And that's why we met with the gentleman, antitrust attorney in DC. And again, what he said is, you're way over here on this side of the line, and we can get closer, and they will threat. So I 100% agree with you, and that's why I'm encouraging more conversations. That's where the strategic contracting series, that's where Antoine said you can go to your neighbor and say, hey, you know what, here's how we should determine what payment is, and we can work through our cost and a reasonable profit. And if everybody used that same process, we would all be advocating for a fair payment, independent and not colluding and doing it. So 100% agree that more of this has to happen. So
yep.
Right.
Thank you all.
Thank you, guys, and more of these meetings as possible. That was amazing. Thank you very much.
Thank you all very much. Appreciate you.
Great.
Thank you. And
So
I hope
much.
to see you all in July at our business development conversation. If anyone has a minute to just hang out and share some feedback, if one or two people can hang back, and that would really help me plan the rest of these sessions. Everyone else, I hope you have a good rest of your day. Thank you.
Good luck, guys.
Thank you.
Thank you.